crack your chest. I don't know if I can run PowerPoint, but I can crack your chest.
You're recording.
That's a great way to introduce this.
Sorry, you want me to start over?
So today we're going to talk about respiratory emergencies and things that you might run into in the field, the most common things. I want to spend a little bit of time, and I know some of this might be a little painful, a little less exciting, to kind of dig a little bit into what's going on, because the goal is to help you make good choices about what things to use to make better. I think sometimes we take breathing for granted. I like this quote. Breathing easily and fully is one of the basic pleasures of being alive. Think about that. I would venture to say that everybody here in the room doesn't have any problems, doesn't have any respiratory problems, at least that we can see. We breathe very comfortably, and for the most part, we don't even notice it. But when you don't have that ability to breathe like you normally do, it's very distressing. And as an example, a couple years ago, I was snow skiing up on Schweitzer with my son, and was going down a run and hit a bump, and one of my skis popped off. It was that terrifying, very brief moment where you're on one ski and you see the other skis start to sail off, and your foot's not attached to it. You know, this is not going to end well as you're going down the hill. And so, you try and sit down or come to a stop, but I ended up tumbling and doing a small yard sail. And in the process, felt this crack on the left side of my chest and was laying in the snow, and my son came running up, Dad, are you okay? And I was trying to talk to him, and I couldn't talk to him because I got the wind knocked out of me, so I couldn't breathe. And it's at that point in time you're like, okay, this is a little scary, this is not very comfortable, and eventually the paralysis wears off and you can start to breathe. And I was able to pick things up and got back in, and for the next couple hours I was trying to keep up with my son as we were skiing, and it was really hard. And so finally I ended up quitting early, and the next day I went to work and I grabbed the ultrasound machine and I started ultrasounding my ribs and found 2 broken ribs. And so I was like, well, now I understand why I have a lot of pain. And for the next couple of weeks, it was really tender. And I remember laying in bed at night trying to go to sleep, saying, all I want to do is go to sleep. And it was hard to do that because with just a broken rib, because every time you take a breath, it hurt. How many people have broken ribs? All right, those of you that haven't, that day will come probably. Just play hard enough. So it's one of those things that we take for granted. And so really for EMS calls, for people that are in respiratory distress, it's a significant issue because it's pretty intense and pretty scary if you normally want to. So there's 2 different things that we can kind of divide this, 2 different categories. There's difficulty breathing, meaning it's physically hard to breathe and they feel short of breath or they can't catch their breath, versus they are having difficulty getting enough oxygen, getting satisfied with the amount of air that they have. And people that are not having adequate oxygenation will tend to become lightheaded or pass out or feel again like they can't get that satisfaction of the breath. Whereas people that have a hard time breathing, they get the oxygen, it just hurts like a broken rib. Okay? So as we look at the different things that you may run into in the field about respiratory emergencies, here's probably the most common ones that we'll see. The allergic reaction, actually hopefully you don't see it very often, but we certainly train for it because it's life-threatening. Respiratory infections, bronchitis, pneumonia, the little old lady that's been coughing up for a week and she's just not doing well. The classic one, the older people that have COPD. Oh, I was smoking for 20 years, but I quit now. But it's too late, their lungs are damaged. Sometimes fluid can collect in the chest cavity and squish up the lung, so the lung doesn't have enough room to expand. Or converse, you can have air leak out into the chest, and so it collapses the lung, and so it's hard to breathe. Most of us hopefully have seen asthmatic patients, and then there's patients that have congestive heart failure, and we'll go into these, particularly the patients that have CHF. So let me explain to you a little bit about these different processes, but it's pretty important to try and figure out what you think may be going on, because the treatments that we have available are a little bit specific. And treating somebody with one problem with a different solution may not be effective and may not help the patient. So it's important to try and figure out, I don't expect you to become physicians, but there are basic things that we'll talk about. So we're going to review the basics of breathing, some of the common problems, and the findings that you would expect to see, and then I hope to link that together with the treatments, the tools in your tool bag that you can use to help these people get better. So why is breathing important? We take it for granted, but basically the first thing that it does is it provides oxygen into the blood, and oxygen is essential. If we take that oxygen away, you die, okay, very quickly. It's necessary because it makes energy, and this is something called the citric acid cycle, or Krebs cycle. I had to memorize this as part of medical school. Very painful, all those terms. And maybe you've seen it in high school or college biology. It's well known. But this whole thing generates what's called ATP. And ATP is the basic functional energy unit of the cells. And you can't make this ATP without oxygen. The whole thing stops. And technically, that's actually how we kill people, judiciously, is in the gas chamber when you give them cyanide. Cyanide blocks one of the molecules at about 2 o'clock in that circle. And so oxygen doesn't get into the cycle, and instantly the cells die from a lack of energy. It takes about 30 seconds. But that's exactly how cyanide works, is it blocks the oxygen function in the cycle. You need to know is, again, oxygen goes into the body, it's used to make energy to keep things alive. The other thing that the lungs do is it takes the waste, it's kind of like the trash can, it takes the waste from the cells and gets rid of it in the form of carbon dioxide. So here's an example. You've got the lungs, and then microscopically, the lungs are not hollow cavities, but it's actually like a sponge. And you see these little air pockets. Some people describe them as like a cluster of grapes. And then if you look at that even more closely, so if we zoom in here, you can see the blood flowing through the blood vessels, and this hollow little cavity inside is filled with air. The oxygen gets into the red blood cells and the carbon dioxide goes out. And so every time you breathe, that happens. So this is the important part of the lungs. And so if something happens with this process, it screws up. So here's an example. If I took your lung, most of you hopefully, if I took a piece out of your lung and I sliced it really thin and looked at it under a microscope, this is what you'd see. This is a normal lung. And so you can see here's a little bit of a larger airway right here. And then you can see these little pockets out here where the air can get into. And these little lines, in these little lines, are blood capillaries. And so the blood will travel through those walls, so the oxygen doesn't have to go very far. It looks very frail, but it's remarkably resilient. It's pretty impressive. So this is normal lungs. Okay. And so you've got all of those little clusters of grapes because it increases the surface area of the lungs. If you think about how much area is inside your chest, it's not really that big. And we need to get a lot more air exchange into those clusters of grapes. And the scientists have gone through and said, you know what? If we took your lungs and we spread them out flat, the average adult lung would cover a tennis court. That's impressive. That's the amount of surface area that is folded and collapsed into your chest. So all of that area is available for air to get in every couple of seconds. When you breathe, it fills that whole tennis court, the gas exchanges, and then you exhale it out. Pretty effective, okay? So a tennis size. And so the impressive thing is that our bodies are able to function like that. So you've got that extensive surface area, and the air that we breathe is actually 21% oxygen. You guys know that, right? When you fill up your SCBA tanks, right? You're just filling it with air that's out here. And the air that we breathe is 78% nitrogen, 21% oxygen, and 1% small gases and carbon dioxide. So the bottom line is, every time you take a breath in, only 21% of it is oxygen. But that's enough, with that huge tennis court crammed in your chest, that's enough to fill up your entire body with all the oxygen that it needs. And you get 100% saturation on room air. Pretty impressive. All scrunched into your chest, with only 20% of the air that you breathe. The other 80% we don't use. Pretty cool. All right, so where things go wrong is somewhere it either affects the air getting in or it affects those thin little membranes. So for example, asthma is something that we see that's common. And basically you can think of asthma as kind of like an allergic reaction of the lungs. They'll breathe something in and the lungs are extremely sensitive to it and they don't like it. And the lungs only have a few defensive mechanisms in place to protect themselves. And one of those mechanisms is to take the airways and to clamp down and make the airways small so that whatever is in the air that you're breathing, it makes it hard for that to get into the lungs. The problem is that it also makes it hard for the air to get in, and we need the air to breathe. I tell my patients breathing is a good thing. We like to breathe. So as you talk to patients that have asthma, they have different triggers. Maybe there's dust, maybe there's mold, maybe there's seasonal stuff, grass or ragweed or pollen in the air at different times of the year, or even smoke or chemicals can get in there and it can cause those air. So what we call that is reactive airways, and it's a process called bronchoconstriction, where the airways become tightened. In addition, the airways become inflamed and irritated. So if you played basketball out on the street, but you didn't wear shoes, at the end of the basketball game, your feet would be a little sore. They'd be red and stuffed up and sore, and they'd be swollen, inflamed. Same process happens in the lungs when they get exposed to something that they don't like, okay? And so what happens is, if the lungs are particularly sensitive, they clamp down, and then they become inflamed, and the insides of the walls become thick and gooey to try and trap what particulate matter is. So here's an example of what it looks like. The normal tubes going into the lung look like this. So you've got the thickness of the airway, and then here's the inner lining. And when an allergic reaction happens, it starts to go the direction to the right, and it becomes thickened, and you can see the airway is remarkably smaller compared to the original size of the airway. Okay? So this can happen for asthmatics. It can happen within a matter of minutes. Their airways clamp down like that. Okay? Airways clamp down like that. The clinical thing that happens is they become short of breath because it's hard to push the air through a smaller pipe. They start to build up air in their chest, and they start to develop wheezing. So think about it this way. If you and I are talking, we're just making standard vocal noises. But if you purse your lips and you blow through pursed lips, you can whistle, right? So you're taking the same amount of air and you close your mouth down to a small opening and you blow that air through there and it turns into a whistle. The same thing happens in the lungs. Normally, they don't make a lot of noise. But when the airway gets narrowed and restricted with the stethoscope, and sometimes even without a stethoscope, you can hear it basically whistling. We call that wheezing. Okay? So now you understand how this works, and you can imagine if you had to breathe through the way that you make your mouth when you're going to whistle, and you had to breathe for like that for the next 6 hours, you get kind of tired. And the asthmatics get tired. They're like, this sucks, appropriately so. So the bottom line for patients with asthma is the airway got shrunk, and it's harder for the air to get in and out. And so now I want you to think in your mind, so if we're going to try and fix or treat somebody that has asthma, what would you do to make them better?
Relax the airway.
Relax the airway. File that one away. Okay. Anaphylaxis. Kind of a similar situation. It's kind of like asthma on steroids. One particular thing, whether it's bees or peanuts or something like that, the body has a massive allergic reaction to it, to the point sometimes where they develop welts on their skin, but it will also affect the lungs. Again, the body is saying, hey, whatever you just got exposed to, I don't like it, so I'm going to try and close everything down so it can't get in. The problem is that you can't breathe. The body doesn't get that. So they have the asthma, the airways become very narrow. And so what you will see clinically is the patient's very nervous because they're basically trying to breathe through a straw. And sometimes they get to the point where they're afraid that they're going to die. Their eyes get big, they start to panic. Instead of settling down and not moving, they start to move around more, which worsens the problem. And in the last stages, actually, you won't hear any wheezing at all because their airways have gotten so tight, they can't breathe at all. So then you don't even hear any wheezing. So when somebody comes in to see me, and I get a history of asthma or some kind of an allergy, and I listen to their lungs and I don't hear any breath sounds, I'm getting ready to intubate the patient because they're about ready to go down. That's how serious it is. Those people are very, very, very scary, and that's when they become hypoxic, which is the medical term for their oxygen levels go down because they can't get any air in. Okay? What it's going to look like, okay? How many people have seen or treated somebody with an anaphylactic reaction? Peanuts, bees, okay? Did it get to the point where they're about ready to pass out, or did they call soon enough and they're like, hey, this, they're going to give themselves a shot of epi or something like that? Has anyone had somebody get close to going down? It's pretty scary. And they're scared, aren't they? They're very scared, okay? So bottom line, similar to asthma, the same principle applies. The airways have been narrowed down and they're very edematous on the inside. So the question I ask you is, now that you know what the problem is, what's the treatment? How do you fix? How do you try and help somebody? Okay, file that one away. All right, let's talk about another airway issue, another respiratory issue, something like pneumonia or a lung infection. So pneumonia is an infection of the tennis court, part of the tennis court. Bronchitis is an infection of the large airways that carry air into the tennis court, okay? So you don't always see that on chest x-ray. It can be caused by viruses, it can be caused by bacteria, but basically when the lung gets an infection in it, that part of the lung kind of does something similar. It starts to secrete all of this snot and mucus that's really sticky in an effort to try and trap the virus and the bacteria that you're breathing in, to trap it, and then it makes you cough. And you cough the mucus up, and it throws it out your body. It's pretty cool. The problem is sometimes it produces so much mucus that it fills up a whole portion of the lung. And when that lung is basically filled up with fluid, no air can get in there, so it makes it harder to breathe. So you get short of breath. Okay? So the fluid can develop into the distal part of the lung or even in the larger airways. And when that happens, I think we've all had that at bronchitis, where you're breathing and you get that rumbling sensation. I was trying to think of a way to describe it. And I remember I was diving last year, and I think most of you have probably at one point in time gone swimming and used one of those little snorkels. and you got the snorkel and you got your face underwater, and you get a little bit of water in the snorkel. It's not enough that you're going to drown, but you get that rattle and that rumble in the snorkel. You know what I'm talking about? You can feel it as you breathe, and you can hear it. It's the same way in patients that have bronchitis. They can feel that, and oftentimes you can even just get close and listen with your ear, and you can hear that rumble. People with pneumonia, where that's a little bit deeper, with a stethoscope, you can hear that rattling going on inside. It's a wet rattle, a wet crackle or a wet rattle is what it sounds like. And so as a result, because there's all this debris and there's all this mucus in there, it's hard to get air in there, and so they can't get the carbon dioxide out. And so this is what pneumonia looks like. So you remember the first lung that I showed you, where here are the walls, okay, and there's supposed to be an empty space in the middle. Instead, the empty space is totally full of junk. Some of this is cells that the body has made and secreted the cells in there to try and kill the infection, but a lot of it's mucus. And so you can see not a lot of air is going to happen in there. And when we look at it on an x-ray, we can see normally the x-ray is kind of black or gray because it's full of air, and so the x-rays go right through it. Where the pneumonia is, because it's so dense with all that snot and mucus and stuff, it turns white on an x-ray, and so you can see that. Okay? So the bottom line, for people that have infections, they get part of their lung filled up with this infected fluid, and so they're not able to get oxygen and carbon dioxide. So basically, instead of playing with a full tennis court, they're only playing with part of it, because the part of it that's full of stuff doesn't work. And so the rest of the lung does okay, but they just don't have basically as big a lung as they normally would because it's been blocked off. Okay? And so the symptoms that you will see is the patient typically for days will be feeling weak and probably have fevers and short of breath, and usually have a cough that's producing something. And you'll hear those wet rattles in their lungs. And sometimes they may be hypoxic, sometimes they won't, but they'll still be short of breath and that rattles. And so the bottom line is, it's full of fluid, and they're not able to get enough oxygen sometimes in. And so then the question is, if that's the problem, then what's the tool that you reach for? What's the solution to help these people feel better? So now you know what's wrong with them. Now you can figure out what to treat them with. All right? Summarize all this at the end. Patients with COPD. COPD stands for chronic obstructive pulmonary disease. It also has a synonym called emphysema. And basically, it primarily occurs almost exclusively to people that have been smoking for years. What I mean by years, it's usually at least 10 years, probably more like 20 or 30. And at a minimum, they're smoking a pack per day is how we quantify it. I've seen people that smoke 2.5 packs a day and smoke it for 20 years. So what we do is we multiply that out to kind of analyze it. We say, well, if you're doing 2.5 packs a day for 20 years, that gives you what we call a 50-pack year history. So 2.5 times 20 equals 50. So that's pretty high. And so without a doubt, these people have damage to their lungs. So what happens is, because they're always breathing smoke in, the lungs, first of all, become thickened and irritated. Just like initially if you went outside without shoes, your feet would be sore. But after a while, if that's all you did for years and years, your feet would kind of get used to it, but they'd be really thick. And they wouldn't be as flexible because they're a lot thicker than everyone else. Okay? And so that's what happens here, is that their airways become thicker and become chronically inflamed. In fact, sometimes it gets so bad that those little clusters of grapes get destroyed. And when you destroy those cluster of grapes, it basically shrinks the size of your tennis court. And so what happens is, instead of living normally over here with an open airway, they're living day to day like this, and then if they get an infection, they're instantly down here. So the walls are thickened, so the airways are narrowed and have a lot of more mucus lining. And so it's harder for air to get in, and for gas exchange to happen. So here's a microscopic slide on the left of a normal lung. And you can see over here, if I can get this, you can see here's a larger airway that's normal and all the small airways. If we look at COPD, the larger airway is really, really thick and more narrow, and the smaller airways are thicker themselves, so it's harder for air to exchange, and it just doesn't work so well. And so basically, in the later stages, in addition, the walls of these clusters of grapes break, and they just get these large areas, but what happens is it destroys the surface area. So instead of having a filter that's corrugated like this with a large surface area, all those large air pockets, there isn't as much space, so you're playing with a smaller tennis court, and they have a harder time breathing. As a result, people with emphysema, it's like half their lung isn't working. It doesn't exist, because they destroyed it. And in fact, when we look at it on pathology, when we cut down up, well, I'll show you that in a second, I guess. So here are the symptoms of it, and perhaps you've seen people like this. They usually have a smoking history, and they come in and they're short of breath. You can hear them wheezing usually when you walk in the room, even without your stethoscope. And typically they're sitting upright, and they're going like this. We call that tripoding. One leg, second leg, and then the chest is the third part of the tripod. They're sitting up like that. And what they're trying to do is they're trying to expand their lungs because they can't get that big breath that they want. So they're really trying to sit upright like this. And if you lay them down or they bring their arms to the side, it collapses their lungs, and they're trying to expand their lungs because they can't breathe. And they live like that all the time, all day long. It's miserable. So a lot of times they'll sit up, and when they get sick, it doesn't take much, and they start to get really, really bad. And a lot of times you can't hear any lung sounds in the bottom of the lungs because they're having a hard time moving air through there. Oxygen levels are already down. In asthmatic, they may not have low oxygen levels, they're just having a hard time breathing. The COPDers, they have a hard time breathing, and their oxygen levels are going down. So what happens with them is their airways are smaller, and they don't have as much of the tennis court to play with because they broke it. And so they're not breathing as well. And so then the question is, now that you know the overall principle of what's going on, what would you do to fix these people? All right. A pleural effusion can be caused by water that leaks out from congestive heart failure or recent surgery, or something that you may see more often is a hemothorax. So a lot of broken ribs, and so blood leaks from the broken ribs and it leaks into the chest. The problem is that the lungs need all the room in the chest to expand. And so if you fill up half of the lung, half of the chest with fluid, then the lung gets squished up and it can't expand all the way. So it's hard to breathe because you can't expand your lungs. So here's an example of what it looks like on X-ray. You can see on the left is a normal lung, and it's dark and kind of black and gray, and that's normal. On the right side, the whole bottom part of the lung is whited out. It's because they have a huge collection of fluid in the chest. In this case, this patient has lung cancer. And lung cancer, for a variety of reasons, causes the body to secrete water and liquid into the chest cavity. And it starts to fill up, and then after a while, the lung is just all squished, and it can't expand, so they can't breathe because their lung can't move. So basically, it's like people that have these fluid collections, whether it's from cancer or from trauma, and there's blood leaking in here, it's basically like taking out part of their lung. It doesn't work. So they have a hard time. So as a result, they become short of breath, and frequently their oxygen levels will drop because they don't have as much lung to use. And more importantly, you'll listen, you're like, yeah, I can hear breath sounds, I can hear breath sounds. I don't hear anything. Try it again. I don't hear anything. Meaning nothing. And so compared to the person that has a bee sting, where you don't hear a lot of air movement, it's because they're all tightened up. These people are breathing, but literally you can't hear anything. And if you try and tap on it, if you go to the grocery store and you're tapping the watermelons, it should be hollow. You tap on their chest and it's just dull thud. There's nothing there. It's full of fluid. So, for these situations, the result is their lung is squished up so they don't have as much area for gas exchange, and so they can't get enough air in. They can't get enough oxygen in. So if they can't get enough oxygen in because they don't have as much space, well, similarly, people that have collapsed their lung, called the pneumothorax, are equally short of breath. And occasionally, we don't know why, tall, skinny males that occasionally smoke can sometimes spontaneously pop their lung. Don't know why. It just happens. I see it about once a year. It just happens. We have to reinflate it. But most commonly, it happens from trauma. And 2 days ago, I took care of a guy. I don't know if you heard about it. There was a pretty bad accident on Bigelow Gulch on the north side. It was a head-on collision about 50 miles an hour. And the guy came in, and I was suspicious for broken ribs just because of the mechanism of injury. He was wearing a seatbelt, but the mechanical forces were so great, and he broke like 5 ribs on one side and just completely collapsed the lung. I didn't hear any breath sounds, and so I had to put a tube in to reinflate the lung. But he was short of breath. The other thing is that patients that have COPD, because they've damaged their lungs, they get these bubbles, and we call them blebs, I don't know why. They get these bubbles, they look like blisters on the outside of the lung, and occasionally they're working so hard they'll pop that bubble, and then the air will leak out of the lung into the chest cavity, and then they got a collapsed lung. I have the picture. So the top left is a picture of a lung, and you can see the black, that's the blood. But at the top, you can see these bubbles. Right here, you shouldn't see any of this. The lung should be smooth, totally smooth. This is all emphysema. And when we look at a CT scan on the bottom right, you can see these big pockets? You shouldn't see anything on a CT scan. The lung, the air pockets in the lung are microscopic. Look, his lungs got 1, 2, 3, 4, 5, 6 chambers to do oxygen exchange. There should be 5 million in there. He's got 6. Because the smoking over the years destroyed the lung, and that's all that's left. And it's those bubbles, and they don't work very well. So that's why they have a hard time breathing. So if they breathe really, really hard, or they get in an accident, pops one of those blebs. Okay? So for pneumothorax, not only can you get COPDers, but cancer can do it, and then occasionally it can be my fault. Though, knock on wood, it's not happening. What happens is I have to put a central line in. I have to put an IV into one of the veins underneath the clavicle or in the neck and float this IV down inside their heart so that I can deliver medicine directly into the heart. And of course, when I'm sticking a needle, a sharp object around the lung, occasionally you can bump into the lung and pop it. We try really hard not to do that, but it occasionally happens. Poor form. So this is what a pneumothorax looks like. Here's a diagram. You can see that basically air has leaked out of the lung on this side, and so there's air that's filled the whole chest cavity, and so it's pushing on the lung, not letting it expand. And that's what's happening in this x-ray. You can see on the left side of the x-ray, it's kind of gray. That's the normal lung. And you can see over here, it's a little darker than normal because the lung is shriveled up right here. This is all air that's leaked into the chest cavity and squished the lung. So basically, he's functioning on one lung right now. The other one is just shriveled up. And that's an emergency. Right. So, the signs of somebody that's collapsed their lung, they're short of breath. They may be quite anxious because it hurts or it's hard for them to breathe. They may have some chest pain. And depending on how long they've had it, they may have some low oxygen saturations, hypoxia. in later stages, as you breathe, one side of the chest won't move because the air that's leaked into it prevents the lung from moving. So one half of the chest will go up and go down. The other side won't move. And in later stages, even the neck will start to shift over. And you may feel crackles under the skin. It feels like that bubble wrap that you use for shipping packages, and you push on their skin and you can feel it crackle underneath their skin. That's air that's leaked out from the lung underneath the skin, and you just start rubbing your hand, it's just crackle, 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 crackle. You just feel it, like, oh, you collapsed the lung. Oh, there we go. And so you can see on an x-ray, this yellow stuff, all this black out, see here's the ribs, this black out here underneath the armpit, that's all air that leaked out. So if you put your hand underneath their armpit, you just feel all those crackles. And so instantly, just by touching it, physical exam, you know what kind of things they have. And so when they've collapsed a lung, it's not working. So instead of playing with a full tennis court, you've only got half the tennis court. So if you don't have the ability to get the other tennis court up and running, and they need more oxygen, well, then they need more oxygen. So then the solution for you would be what? Since we can't get the lung up, unless you're a paramedic, then you can treat with a chest tube or needle decompress. Bagging may be an option. What would you bag them with? Yeah? 15 liters? Yeah, exactly. Because remember, room air only has 20% oxygen. They're going to need more oxygen. And that's exactly it. All right. So the last one, I think, is congestive heart failure. And so this is basically a problem with the pump. And this happens as we get older. Sometimes the heart just doesn't work as well. Sometimes somebody has a heart attack, so part of the heart doesn't work as well. Or sometimes the valves inside the heart don't work as well, and so it's not as efficient. The bottom line, the heart doesn't work well as a pump. So if you wanted to go out and fight a fire, and you weren't allowed to use the pump on the engine, and you had to use the swimming pool pump that you have at your house, the 1.5 horsepower pump, how much water would you throw on the fire? Not much. It ain't moving. And that's what happens with heart failure. The heart and the lungs are tied together. So something that affects the heart can screw up the lungs. And believe it or not, something that screws up the lungs can affect the heart. And so in this situation, the heart is not moving well, then fluid backs up in the lungs. And what we have here is an example of fluid that's just slowly building up in the lungs. It's become a little more dense down here in the bottom because fluid is heavy and it follows gravity. And so literally their lungs are filling up with water. And so you can see, if you look carefully, here's a microscopic view of the lungs. It kind of looks like the one that I showed you with pneumonia, but you can see it's filled with pink stuff, which is stain from the process. It's not filled as much with all the cells and junk. So literally like this, the air pockets are full of water. And you can imagine that's not going to work very well. You can't exchange oxygen if the air pockets are underwater. And so as a result, people with congestive heart failure, they have both tennis courts, but half their tennis court's underwater. So it doesn't work. So what they have is typically say, if you had any heart problems, and half the time they've had a heart attack. Half the time, if you ask them and say, if you had a heart attack, they may say no. So I'll say, do you have any heart problems? Because then they're like, well, I haven't had a heart attack, but I have congestive heart failure. Okay, well, thanks for making that distinction. I appreciate that. They have heart problems, and so it tends to build up. They'll become short of breath. And the key finding is, I'll ask people and say, when you went to bed last night and you laid down, was it hard to breathe? Oh, I couldn't even lay down. I had to sleep sitting up in the chair in the living room last night because I couldn't breathe. Ding, 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 ding. So remember I showed you the picture of the tennis court, and the bottom part of the tennis court is underwater. So that's when you're vertical. If you lay down, that water is going to spread out over more of the lungs, and they literally feel like they're drowning. And so they sit back up because it's not as bad. They're like, okay? And so as a result, because this fluid is leaking into their lungs, they don't have as much area for gas exchange. So they don't have as much surface area, and they need more oxygen. So then the solution, well, let's put all this together. Let's look at the tools that you have in your toolbox. The most ubiquitous one is oxygen. The next one is albuterol. So if you're BLS, you can assist. If you're AEMT, you can pull out our albuterol and you can give it. We have epinephrine, okay, and CPAP. And I put ALS on there, but things have recently changed in the last 12 months where the state and our county director have made it available to BLS units. We have not implemented that here in District 10. In the Heights, are you guys running CPAP on BLS rigs? Okay, I didn't think so. But you guys, a lot of times will have medics who can start that. Do you carry that equipment, or you just let AMR do it?
I think we carry it, but we don't use
Yeah. Usually they're bad enough and AMR says, all right, let's do it, and they hook, it's easier, and they hook them on and let them go. So we'll talk a little bit about CPAP because this may be coming to a theater near you soon. And the last one is intubation of the King Airway. So let's look at these treatments, and then the goal is, now that you know about the respiratory problems, and once I talk to you about the treatments, then the key is to just connect the dots. Which treatment works for which problem? And you guys are experts. Okay, so let's look at oxygen. Okay? So one of the things you can do is give oxygen. The first thing you should do, and I'm going to hunt people down if you don't do this. The first thing you do when you arrive on the scene is you put a pulse ox on somebody and see what the crap their saturations are before you do anything. How do you know if you're making them better if you don't know where they started at? Well, he was working really hard. That's cool. Let's get a number. Put the pulse ox on. It doesn't take long. It takes 10 seconds, and see where he's at. So if he's starting at 84%, that gives you a lot of information right there instantly. Plus, it gives you a tool to kind of figure out how you're doing. So we use oxygen for people that feel short of breath and they are hypoxic. Just because you're short of breath doesn't mean you need oxygen. You see an asthmatic, and he's doing 96% on room air, doesn't need oxygen. In fact, some of them get nervous. You shove a mask on their face, and they feel claustrophobic. You make them nervous. Now, if they're getting to that point where they're going to collapse, absolutely put the oxygen on, because we're going to need all the reserves we have, but that's generally not the case. So they're short of breath, and they have decreased oxygen. For definition purposes, if their saturations are below 93, you can go ahead and give oxygen. And the mechanism is, how this works is basically, instead of breathing 21% oxygen, by giving them oxygen, we're increasing with each breath. If you breathe in 500 cc's, 20%, well, let's do it a liter. Make my math easy. If you breathe in a liter, then 200 cc's of that liter is oxygen. If we put oxygen on you, you still breathe in a liter, but instead of 200 cc's of that liter being oxygen, maybe it's 300 cc's of that liter is oxygen, or 400 cc's. And so we adjust that. You can do it by nasal cannula. Okay, so you put a nasal cannula, and that will increase somebody from 21. It can increase their oxygen concentration to 23 or around 40%. So then, some people are guppies. They're mouth breathers. Have you ever seen this? The good AMR medics will notice this. They'll pick up on it. The person's in a lot of distress, and you got the cannula on, you got it up to 5, and they're not getting better. So they'll just pull the cannula down and put it in their mouth. I don't care. It works just fine. If that's how they're breathing more of the air is going to come in through their mouth, and it works. So if you do it that way, you can actually dial the oxygen up a little bit more. If sometime you ought to, when you go to put oxygen on somebody, you should put it on 2 liters and put your hand in front of the prongs and feel the amount of force. Dial it up to 4, feel the pressure. Dial it up to 6, feel the pressure. Now in your mind, try and sit there and say, how's that going to feel in my nose at 6? That may be a little uncomfortable. And that's why we kind of say, if you need to go more than 6, people are going to be blowing their nose out. That's a little uncomfortable. So you can go higher in the mouth because it's easy to do. But if it's getting to that point, you can change them over to the non-rebreather mask. And you dial it at 15 liters, that can get you 80% oxygen, and it all depends on the seal. So if they make a really good seal around the mouth, and those elastic bands are tight, you could almost get 100%. So depending on how much of their tennis court is underwater, you may need to adjust and get more with every breath that they get. Instead of, if they can't take a liter, they can only get 500, then you want all of that 500 to be oxygen instead of 100. See what we're doing? We're increasing the oxygen concentration. So, the indications for giving oxygen is going back to they don't have as much tennis court to play with. So the examples is part of their lungs is filled with fluids, so an infection or congestive heart failure, or part of their lung is squished, so a pneumothorax. So that lung isn't working, so the other one that is, we want it to have way more oxygen, so it balances out. Or their tennis court has a whole bunch of holes in it, and so they don't have as much surface area, so a COPD. In some cases, they can't get enough air through the tubes, and that's the asthma patients, the anaphylaxis, as well as the COPD, and they can benefit from oxygen depending on what their saturations are. The next tool in your tool belt is albuterol, okay? And what did I say? What's the first rule? You have to get a pulse ox, see where they start, okay? And I'm just going to ask you what the mechanism is, but I put it up there. So basically what albuterol, go back to this picture. So if somebody has an asthma attack, and this is their normal airway, and within a couple of minutes, it shrinks down and gets tighter to this, the albuterol is a chemical, and it will cause the green arrow, and it will shift you back, not all the way, but it will try and open that airway up so they breathe better. So now you know what albuterol does, and since you know how it works, now you know what processes to use it on and what processes won't work. Okay? So, here are the things that it works for. It works for people that have bronchitis or asthma or bee stings from anaphylaxis or COPD because they have chronic constriction. Okay? People with pneumonia, it's not going to work. Because the people with pneumonia, they don't have a problem with their airways getting narrowed. They have a problem with their airways being full of junk. So albuterol won't work. So the basic way for you to figure out is this a patient that albuterol is going to help? What did I tell you clinically you would find? What does it sound like when that airway gets narrow? What can you hear? Wheezing. Wheezing. If you hear wheezing, albuterol will work. That's the clinical key. And people with pneumonia, they don't wheeze, because that ain't the problem. In fact, if you give somebody pneumonia, if you get an old person with pneumonia, albuterol, it can make them worse. It's going to make their heart rate go up. Well, then there's epinephrine. Epinephrine is like turbo mega albuterol. It turns everything on, it ramps everything up, it maximizes everything. And so it's going to saturate all the receptors in the body, and basically, somewhat like albuterol, the green arrow, it's going to try and briefly open up these airways, and it'll go a little bit further than albuterol, and it's going to dilate those airways. Think about it. You're hiking in the woods, and a bear jumps out in front of you. And all of a sudden, you get jittery. That's because epinephrine, your body is dumping epinephrine into your body, and all of a sudden your eyes get big, and the body shunts all the blood to the muscles and to the core, and all of a sudden you can breathe a lot easier. Because your brain says, I need your airways open as much as possible because you're about to run. And when you run, you need all the air you can get to keep running until the bear disappears. So it's going to dilate your airways. So that's how epinephrine works. Okay? So epinephrine is fight or flight, and it turns everything on. The indications are, according to county protocol, is if there's severe respiratory distress and oxygen compromise. Their oxygen levels are going down. So the indication for that is a severe asthmatic that is just not turning around after initial treatment, or anaphylaxis, bee sting, or some little kid eats a peanut butter sandwich and they get an anaphylactic reaction. Now, as a result, it will pump your blood pressure and it will pump your heart rate, but it's a kind of a trade-off. We can't say, well, we're not going to give you this medicine because you're 65 and we don't want to hurt your heart, but then you die because you can't breathe. That doesn't work. So, and again, as always, if you ever have questions and you're not sure what to do, we're available 24 hours a day by phone. Okay? CPAP. CPAP is cool. CPAP is now being used by a lot of people that have apnea. We use the same device in EMS, the same principle. The people that have sleep apnea, they sit with this little machine on their nightstand next to their bed, connected to this tube. I was going to get a picture of, how many seen Aliens? This looked like the Aliens thing, But I thought I would cause horrors or nightmares or something. But so they sleep with this mask on, and basically what it does is, constantly, 100% of the time, it's just blowing air in your face. That's all it does. And so the EMS version is, we have a similar mask that you strap on, and there's a flow regulator device right here, and you hook that up to an O2 tank. And the pressure of the O2 tank will drive this and create enough pressure. And what I explain to patients is, it's just like you're driving on the freeway at 60 miles an hour, and safely, you stick your head out the window and open your mouth, going 60 miles an hour, and it's blowing air in your mouth. That's CPAP. Okay? It's just blowing air. You can breathe. Sticking your head out the window, you can breathe. In fact, it's a lot easier. You never tried it? Somebody else needs to be driving, then you do it and see what happens. Okay? So is you have this mask and it's blowing air represented as green, and the key here is that the air gets blown in, and back here where there's a constriction, this is for people that have sleep apnea, where their tongue drops down and collapses the airway, the air blowing into their lungs constantly keeps that open. And so they breathe all the time when they lay down. Okay? We're using the same thing, except that pressure goes all the way into the lungs, and it helps people whose lungs are underwater, for example. If the lungs are full of water, how can we get rid of that water? If we push air into the lungs and push the water out, now those air pockets are dry and empty, and you breathe better. It's pretty cool. So, how does it work? It's got a fixed regulator, a fixed device that regulates how much air, because it doesn't matter how much you turn on the oxygen tank. There's this special valve, so that it gives them a special pressure. It's usually 5 centimeters of water equivalent. So you turn high flow oxygen on, and in EMS, so not only does it create that pressure to help open up their lungs, but it's also giving them oxygen, which is great, because typically the two will go hand in hand. but it has to be a tight-fitting mask. And be careful, you will blow through your oxygen tanks really fast. 10, 15 minutes tops on the tank. Just empty it. You need it. We don't have that here right now. We're going to start investigating that, but you've seen AMR will do it, and it makes a difference, and it will save intubation. I've saved a lot of people not having to intubate them by using CPAP. It's a huge thing. So, how do you use it? People that have COPD, maybe asthma. So COPD, the airways are narrow, and so you're trying to blow those airways open, or people with pulmonary edema, so congestive heart failure, push that water out of the way. Occasionally some pneumonia, that may help if they're really, really low on oxygen, that can help open those airways, okay? Now, you can't put everybody on CPAP. If they're too sleepy, you can't put them on CPAP, because if you start to get nauseous, the patient has to be able to reach up and rip the mask off their face, so that if they throw up, they throw up. Because if you have the mask, it's like sticking your head out the car at 60 miles an hour, and you feel sick, and you're going down the road, and you throw up. Where do you think it's going to go? Your mouth's open. It's going to come right back. Come right back, and you get to taste it. In this case, it'll go into the lungs, and then they get really sick, and sometimes they'll die. So the stuff that's in the stomach needs to stay in the stomach. They can't go in the lungs. So if they're vomiting, or if they're too sleepy where they can't recognize that they're going to get nauseous, can't use CPAP. If their blood pressure is low, CPAP will lower your blood pressure. The reasons why are beyond this discussion, but it will lower your blood pressure. So if you're starting with a low blood pressure, can't use CPAP, because it'll make you worse. If you're having a heart attack, can't use CPAP. So if you roll on somebody that is having chest pain and you're concerned about a heart attack and they're hypoxic, you don't want to use CPAP on these guys. You can give them oxygen by nasal cannula, but you don't want to blow air in, because it makes it a little harder for the heart to work. The vast majority of the time we don't notice it, but if you're having a heart attack, you don't want the heart to work any harder. Okay? And of course, if their face has been chewed up by a dog, or they were in some car crash and they're not breathing, it's kind of hard to get a good seal if their face is messed up. So you can't use it with trauma or. Okay. So if you do use CPAP, the time that you decide that it's time to get rid of it and go to an advanced airway is these. If they get if they get tired, they're wiped out, their asthma attack is going so bad, they're exhausted and they're not breathing anymore because they're just tired, you're done. Take off the CPAP, it's time to intubate. If their blood pressure falls, CPAP comes off. If they become unconscious, or in some cases, the CPAP is supposed to fix the low oxygen levels. Instead of the oxygen concentration going better, if they get worse, take it off. Okay? There's something else going on, and ALS will have to figure that out. All right. So the last one is the advanced airway. We've talked about the King airway. Here's a picture of what it looks like. It allows us to secure the airway and directly push air in and let it come out. And so it's really cool because it will protect the airway from blood and mucus and secretions, and it will help people that if they're playing with a smaller tennis court, if their lung has been collapsed, this will help. Picture. Oh, so what's the hardest part of putting a King airway in? Anyone know? What's the most difficult part of the procedure? Getting it to seat. Getting it to seat might be one, but that's not the right answer. What's that? Yeah, those things are stubborn, aren't they? What was that? Getting the right tubes, getting the right size, whether you're using a 3 or 4. Getting in the right? Yeah, you know, the combi tubes were a little bit harder because those were, hopefully the Kings or an LMA. Have you guys heard about eye gels? So those are starting to come out. City and Valley are deploying them, and we'll probably start deploying them out here. They're pretty slick. The cool thing about them with the eye gel is that there's a port that you can put a tube down into their stomach, and you can suck all the beer and nachos out so they don't throw up. So that's a good thing. The hardest part of placing a king is deciding when to do it. I know that sounds academic, but it really is, because I guarantee you, if they're unconscious and they're dead, you're gonna be like, oh, we need to put one in. But the asthmatic patient that's having a hard time breathing, you're gonna be sitting there and you're like, should we do it? No. Should we do it? Oh, not yet. Right, you decide. No, I'm not gonna. You decide. You're like, when do we do it? And then, so do you wait till they collapse and they're unconscious and then they're blue? It's hard. It's a difficult decision. So I just wanted to review with you the reasons why we put an advanced airway. I can never tell you definitively. You just have to understand the principles, okay? So, reasons why we put an advanced airway. You're worried that stuff's going to fall into the lungs. Blood, secretions, broken teeth, something. You want to protect it. Maybe the most common one is you need to get more oxygen in there, and it's just not getting in there with a non-rebreather, so it's time to get higher oxygen with an endotracheal tube. The need for positive pressure ventilation, so maybe they have really bad CHF and the CPAP's not working, so I've intubated people for that. The need for them to breathe, so people that overdose on drugs. Normally we can get them back with Narcan, but there are other drugs that are out there, and if they're not breathing, well, it's time to put an advanced airway and breathe for them, okay? Or an obstruction, like asthma or anaphylaxis or trauma. So those are the reasons. So the indications can be if somebody's got COPD or CHF and they're unconscious, or respiratory failure, like I said, somebody that has a bee sting reaction, or they're hypoxic, and they become unresponsive, and of course the code of rest is to use the advanced airway. And so this is how the King airway works. And the vast majority of the time it's got the curve designed so that when you shove the tube in, it actually goes in the throat, leading to the stomach. We want it to go there. This is the one time we want it. Most of the time we want to go into the trachea, which is the front pipe. But when you put it in, and he was talking about seating it, you blow up the you blow up the balloons, and then you pull back, and normally you hub this. Normally you hub the King airway, and you shove it all the way down here. You blow up the balloon, and then you start to pull back, and when the balloon gets out of the windpipe and behind the tongue, it snaps open. And then you know you're in the right spot, because now the balloon is blocking the upper part of the mouth. There's a smaller balloon that's stuck in the throat so that the vomit can't get through. And this little area right here has the hole. So when you push air in, it comes out of the hole and goes into the lungs. It's a very elegant solution. Okay? So that can be people who are in respiratory failure. So let's look at this. You're called for somebody in respiratory distress. First rule of thumb, BSI scene safety, don't become the next victim, okay? The next thing is, before you even get your equipment out, what's the patient look like, okay? What do they look like? You know that guy? So, you know what movie that's from? Yeah. He was kind of Benadryl. Probably should have had Epi-shock, but he had that. So you got somebody that just looks sick, and so you think, maybe they got a lung infection or pneumonia. This guy's got some kind of allergic reaction to something, so that's just a subtle hint that something might be going on. And then there's this guy that we talked about earlier that's tripoding. So that gives you a hint that there may be something like COPD. So what's the big like? And then after you do that, try and take a history. Hey, do you have any lung problems? Yeah, I have COPD. Cool, he just gave you the answer. Or, yeah, I have heart problems. Okay, well, let's start making you think about things. So then you do your vital signs. And again, before you intervene, get a set of vital signs. You know where they're at. And more importantly, it helps you decide what's the right choice. So, and part of your assessment, there's that dangly thing that hangs around your ears. It's not supposed to be hanging around your neck. You stick it in your ears and you listen to the patient. And how you do it is you listen you compare one lung to the other. So don't listen here, here, here. You actually want to listen here and then listen over here and compare the sides to each other. Then you can come here and listen here. And then go down. Listen here and go here. Compare one side to the other. You know that's why we're symmetric, right? God made us symmetric, not so that we look nice, it's so the doctor has the side to compare with, so he knows which one's broken, and another side to work with. Okay? So, and then once you have their appearance and maybe a little bit of history, you've got their oxygen level, and you listen to their lungs, within 30 seconds, you can narrow it down and say, well, what's wrong with them? And since you now are experts on what could be going on, and you know what tools you have, you pick the right tool, talk about what those are. So let's give you an example. Here are the categories on the left. Let's take a patient. His appearance is he's tripoding, and he's got pursed lips. And you'll see this. What they're doing is they're breathing like this. And what that is they're doing their own CPAP. Because when they purse their lips, they're blowing out, but as they blow out, they're creating pressure in their lungs to try and expand their lungs. It's called auto-PEEP, is the technical term for it. But they're doing their own CPAP. So it's telling you already. And they're tripoding like this. Their saturations typically are low, and they're breathing faster. And when you listen to their lungs, you're going to hear wheezing everywhere. All over the place. You'll hear wheezing. So, the first question is condition. What's their problem? What do you think their problem is? What disease do you think they have? COPD. And so, what's the problem that happens with COPD? What's the mechanistic problem? What's wrong with their lungs? It's closing up. The airways are narrowing, and their tennis court's got holes in it. We call those bulla or blebs. So, since their airways are narrow, and part of their tennis court has got holes in it, so they don't have as much surface area, what do they need? They need oxygen, and they also need albuterol. So basically what they need is we need to expand the airways, and we need to get more oxygen in them. So now that you know what they need, then you look in your tool belt and you say, oh, I got something. I got albuterol and I got oxygen. You're fixed. This person is distressed and they're in a lot of pain. Their oxygen levels are starting to drop. They're not breathing fast, but it hurts every time they breathe. And their oxygen levels are going down. And you start listening to their lung sounds, and you can hear lung sounds on one side, but there's nothing on the other. Nothing whatsoever. What's wrong with them? Yeah. Either there's fluid in there, something's not letting that lung work, or it's collapsed. Because you got no lung sounds whatsoever. So then what problem do they have pertaining to air? Well, in effect, part of their tennis court has been reduced. They don't have as much lung to work with. So can you give them more lung? Do we have the ability to do that? No. We can't give them more lung, but what can we do instead? We can increase their oxygen, and sometimes, depending on the condition, we can increase the lung size. So the answer is to give them oxygen, okay? And if worst case scenario, you can try some positive pressure ventilation. Good. Making progress. So the next one is short of breath. Their saturations are normal, maybe a little on the low side. And the respiratory rate, they're not breathing fast. They just feel short of breath and they can't get the satisfying breath that they need. And they're kind of hovering in the high 80s, the low 90s. And you're like, well, I don't know what that is. So you use that stethoscope and you listen and you hear these wet rattles in one particular part of the lung. On one side, these wet, coarse rattles. All right, so what do you think's wrong with them? It's been going on for a week. A little old lady, some kind of fluid in the lungs. Okay. And the saturations are low. So it could be an infection or it could be CHF, either one. Fluid in the lungs is the right answer. So they've got fluid in the lungs, so part of their lungs doesn't have the ability to work. So what do they need? Because their oxygen levels are dropping. What do they need? They need more oxygen, and we need to drain that fluid if possible. Okay? So what tools do you have? Well, we can give you oxygen, nasal cannula, and if necessary, they get really bad, we can start blowing air in to push that water out, and they breathe better. Nicely done. Okay? This one's trying to catch his breath. He can't get breath. He's having a hard time breathing. And his respiratory rate's really, really fast. His saturations are normal, but he's got wheezing everywhere. He can't catch his breath like this. What do you think's going on? Yeah. So some kind of allergic reaction or asthma. And so what's the problem with his lungs? What's broken in the lungs? Yeah, the airways got narrowed. So since the airways are narrowed, what we need to do is do what to the airways? Make them big. And do you have a tool that does that? You sure do. It's called albuterol, or in severe cases, epinephrine. Hopefully, this provided you a context. I'm sure you studied this in your classes, in your EMT classes. My purpose tonight was to present this information in a little bit different, organized way. And it doesn't always work for everybody, but hopefully it makes a little more sense. It helps you think it through. What's the problem? What tools do I have? And what's the solution? So, let's summarize. A patient has the abrupt onset of shortness of breath, wheezing in all the lung fields, but has normal oxygen saturations. What should be your first tool that you reach for to help this patient? Abrupt onset of shortness of breath and wheezing everywhere. Pulse ox is normal. So what treatment should you first reach for? So 2 people know. So the patients that are cared for by the rest of you are screwed? How many say A? How many say B? How many say C? How many say D? Good. C is the right answer. This is an asthma attack. Okay? And so you hear, remember what I said? You hear wheezing. And the tool that's in your tool belt that treats wheezing is albuterol. Okay? All right. Now, a patient has worsening shortness of breath for days. And you listen to the lungs, and there's wet crackles everywhere. That snorkel sound. It's everywhere, and their saturations are low, and they have a history of congestive heart failure. What's the first tool you should reach for? Who says A? Who says B? Who says C? Who says D? Did everybody vote? Oh, should we keep track? So the first tool that I would reach for would probably be oxygen, because their oxygen is low. And a lot of times that will help them temporarily. If they get worse, absolutely you're correct. The next step would be CPAP. So I agree with that. And of course, most of us right now, we don't have CPAP. So that's why I said first choice, go with the oxygen. Do you understand why albuterol is the wrong answer? Does that make sense?
It's not an airway problem.
It's not. Exactly. That's what I want you to think about. You guys are smart. Excellent. I can't tell you how many times people bring patients in. Yeah, he's short of breath, so we get 2 breathing treatments. I'm gonna take him out in the back and shoot him. Yes.
Sir, you said that if their blood pressure is low, then you're not going to see that.
Correct. If their blood pressure is low, we're stopping.
Saying like low, like 100 below, or?
So, body habitus plays a role, but I think that's a nice cutoff. If their blood pressure is lower than 100, then I would be nervous. If it's in the 90s, then I would call medical control and say, here's what's going on, here's what I'm thinking, what do you think? And we'll talk you through it. If it's below 90, I think we're stuck. So then I would just give them 100% oxygen, and if they pass out, then now you have the opportunity to intubate, and it fixes it. Next scenario, a patient has a fever and a wet, thick cough for days, and then you listen to the lungs and you get data and you hear crackles, wet crackles on one side, but the other side's okay. The saturation's not bad at 88%. What would be your first tool of choice to help this patient? You're short of breath. How many say A? How many say B? How many say C? How many say D? Nicely done. Let's give her some oxygen. What do you think's going on? Yeah, pneumonia. Got a lower level pneumonia. Needs a little oxygen, so part of the tennis court is full and non-functioning. So we can't get any more tennis courts, so we need to get more oxygen into the tennis court. Give them oxygen. Done. A patient got stung by a bee and has wheezing. Now this is key. I said inspiratory wheezing and is gasping for air and collapses unconscious to the ground. I probably should have done this in 2 stages. So, collapses unconscious to the ground. How many people say A? How many people say B? How many people say C? How many people say D? Not everybody voted. So this person's screwed for the people that didn't vote. So the answer is B. If they collapse and they're that bad and they collapse to the ground, they're unconscious, then it's time to intubate them. If they hadn't collapsed to the ground, and you hear inspiratory wheezing, the next time you go on a respiratory case, it's most likely going to be asthma or COPD. Pay attention when you listen. Watch them breathe. And you should hear the wheezing when they exhale, not when they inhale. COPD and asthma, the airways are narrow. You'd think that if the airways are narrow, it should make a noise going in and out, but it doesn't really as much. It makes more noise going out because they have to work harder to push it out. So when you hear wheezing going in, that's a very, very bad sign. Bad things are about to happen. And so typically that happens in anaphylaxis, and that person's going to go down. So you can reach for oxygen, and if you can get albuterol in there before they collapse, that's great, but bad things are about to happen if they're wheezing when they breathe. I think it's the last one. A patient with lung cancer feels short of breath, and you put a pulse ox on, he's got 81% on room air, and you listen with your stethoscope, compare the right to the left, and the left is empty. There's nada. No breath sounds whatsoever. And he's short of breath, he's got an oxygen level of 81%. What's your first treatment? A? B? C? D? Excellent. A. Correct. So he probably has a fluid collection in his chest that's squishing the lung up, so he doesn't have as much of his tennis court. And since we can't get the tennis court back, then we need to put more oxygen onto the tennis court, and the answer is A. Well done. All right. So in summary, listen, get your oxygen saturations first. If you hear wheezing, the airway's getting narrowed, your treatment is albuterol or epinephrine if they get bad. In severe COPD, not only can they benefit from albuterol because they're wheezing, the studies show that if they're really bad, they can also benefit from CPAP if it's available. If their oxygen levels are low, with rare exception, the general rule is you can give oxygen and they will improve. So that's a good rule of thumb to use. And if you hear wet, coarse crackles like the snorkel, there's fluid in there. So increasing the amount of oxygen as well as trying to get pressure to push that fluid out, if available, will help the patient. And that was it. I know it was a long night tonight, but I appreciate you staying with me.
That was good.
Quick question.
So with the new apparatus, if you're gonna
So if you're using non-rebreather, they're only gonna take in as much air as they can get or they need, but the air that they are gonna get is concentrated oxygen, and that will keep them alive longer, because you're gonna fill up this lung with concentrated oxygen. Converting them to positive pressure, so intubating a patient who has a pneumothorax, you're right, that will make that worse, and they can code. So you have to be aware of that. That's what we teach the medics, and say if you intubate somebody, if your oxygen levels are dropping, they may have a collapsed lung, and you've got to decompress it to get rid of it.
happen with the king as well?
Yes, it will. Yeah, good question. All right, so would you do me a favor so I can get you guys out quickly? Under a medical module, would you write down a respiratory emergency, but the